Sorry, we can't hear you, so we'll increase. Just increase the volume.
आवाज कम करो उधर का. Yeah, 20 हो गया ना?
Yes.
Anterior and we are getting diaphragmatic contraction, then we have to be a bit in.
No, you have to go posteriorly.
See for diaphragmatic
No.
contraction.
If you are getting a diaphragmatic contraction, that means you're anterior. Okay, you're on the anterior scalene. So you need to move a
Every
little
time we have
posterior.
to see while we are in interscalene side. We have to see, we have covered, I think, and it is not visible here.
No. If you are actually seeing, you don't have to look for the diaphragmatic contraction, but if you actually see diaphragmatic contraction, that means your needle is too anterior. It is going over the anterior scalene. Yeah, so you only need to come out and redirect the needle a little posteriorly. Yes, you can actually go deeper. That means you're going through and you're going towards the plexus, but you're going lower down.
But it is not subcutaneous.
But that's not the idea. Not the idea to go through the splenic nerve.
The needle
You might be damaging it.
slightly outside. It will go subcutaneous. Can you see this part filling up?
It doesn't matter. There was no diaphragmatic contractions.
दर्द कम हो गया क्या?
If you get the right response, you will not get diaphragmatic contraction or straightening of shoulders. You will never see that.
बात करो. दर्द कम हो गया सब.
તમારો દુખાવો ઓછો થઈ ગયો હે દુખાવો ઓછો થઈ ગયો
Tingling numbness.
I think if you are actually using very high current, you can actually stimulate the
ભારે લાગે
diaphragm
છે
muscle properly. But if
એ
you're
આજે
using
આપણે
1.5,
ઓપરેશન
you don't
કરવાનું
feel
છે એ હાથમાં ભારે લાગે છે જરાક થોડું ભારે લાગે છે
How much you give? I give 40 ml. सर्जरी होना है इसका.
20 ml
Only am I?
This is उनको बोलो कि ऐसे ही ना 25 ml.
ભારે લાગે છે ભાઈ બસ તમારે એમ જ રહેવાનું
ठीक है. उसको चलो हाथ पकड़ो.
આ હાથ છે ને તમે મુઠ્ઠી વાળીને પકડો આ મારી આંગળી મુઠ્ઠી વાળીને પકડો
Weak. It is weak. Yes.
પકડો
It will come because this is the last one to go. Last one to go. But this is the first portal here. His pain would have disappeared now. You move it, you won't feel the pain.
અરે ભાઈ સાંભળો તમે હા બસ
दूर से दिखाओ एकदम.
His pain will be gone.
Can you see? ये देखो इधर देखो.
બોલાય
दर्द कम हो गया क्या? हाथ सुम हो गया?
દુખાવો ઓછો થઈ
पहले
ગયો
दिखता था ना? See? I am testing whether the block is working or not. It's a big upper third fracture, so obviously it's pain free. Okay, the block will set in within 15 minutes. सुम हो जाने के बाद अभी शुरू करेंगे. हाँ, अभी तो सुम किया है. Okay? Any more questions? हाँ? नींद आती है. Correct. Good. Remove the sedation series. How much were you? Not more than 5. But here we are doing the case totally under the block. So I am not that much conservative. I generally make the volume 40 ml. So the block works well. So it was not pure 2% and this thing, it was diluted by normal saline. So I made it something like
Hello, sir.
0.15% or something like that.
Hello.
हाँ बोलिए. Go on.
What can you do to extend the effect of this block?
Yeah, you mean to say adjuvants? Adjuvants can be added, there are controversies regarding adjuvants. You can add clonidine, 30 mics or dexamethasone. But regarding dexamethasone, there are still controversies. So I don't use. Normally this block lasts 7-8 hours. Patient is pain free for 7-8 hours. So no need of any adjuvants just now. But otherwise, if it is a shoulder surgery, arthroscopic surgery, I put a catheter in it. So to make it for continuous pain relief, I put epidural catheter. Huh? Catheter, there are Contiplex needles available. Otherwise, there is one modification which I have made. Yesterday, I was about to show that video, but because of time constraint, I didn't show. I use a 18 gauge intracath and through which I pass a 10 centimeter needle. I get the block, I inject with the block, then I take an ordinary epidural catheter without the needle and pass it through that intracath once I remove the needle. And then I keep it at 2 to 3 centimeter inside. I can't listen properly.
Sound, please.
Huh?
Because
If you are using Interscalene blind block, I can allow block 4 weeks of TNS.
No. With PNS, 18 gauge intracath is threaded over a 100 millimeter needle first. Then, like I did just now, I elicit the response with the 10 centimeter needle. Then, once the response is there and I inject them, then I insert the threaded 18 gauge intracath over the needle inside. Then I remove the needle and then I pass the catheter. We'll see if there is any side effects. Aankhein kholo. Aankhein kholo. Aankhein kholo. Huh? There is no ptosis, no side effects. नाम बताओ. नाम बोलो. So no hoarseness. So at least immediate side effects are not there. Diaphragmatic palsy, if it's on one side, it doesn't manifest generally. But it's only manifest on X-ray. So clinically it's not relevant. Unless the patient has some respiratory problem. Now we have to check for the superficial cervical block. I will check whether the superficial cervical block has taken place or not. ये देखो, सुई इधर लगता है ना ये लगता है ना इधर, सुई लगे चाहिए, अभी ये लगता है ना इधर, ऐसा इधर लगता है क्या अभी? लगता है अभी? नहीं लगता, इधर लगता है? नहीं लगता, ये देखो इधर लगता है ना, ये जैसा लगता है ना राइट साइड में, लग रहा है ना? अभी ये लग रहा है कि इधर? सिर्फ लगता है, चुभता नहीं है।
पता चलता है वो।
Superficial cervical block is not there. Sir, continue. हाँ, ये थोड़ा नीचे कर सकते हैं क्या? Yeah, I want to show the supplementary block. If superficial cervical block is not there, you have to inject the local remaining local 5 cc or so in a V-shaped manner like this. So that covers the block of the supraclavicular nerves.
There is a question for you.
Yeah, please go on.
I wanted to ask when we are giving the LOR distributive PNS outside,
No, this is not a LOR block.
we are giving.
Huh? Blind technique you mean to say? No, I don't practice blind technique. But blind technique is same, na? You have to know the anatomy, keep the fingers fixed, insert the needle in the plexus, inject. It is the extrapolation of using a nerve locator.
My question is,
Huh?
there is a single muscle or some place where we can ask the patient if he is feeling anesthesia or not, which can give us more surety.
You want to test whether the block has acted or not?
Exercise, some patients will be
Yeah, that is a good question. That is a good question.
because I don't have
Yeah, that is a typical, they say na, push, pull, pinch, 4 P's. Tell him to check for elbow. Check for elbow. Whether he can pull, over down. Tell him to push. If it is pushing, this is pull, push.
Pinch,
And what
pinch,
is?
pinch.
Pinch and prick.
No, this is, that's,
Sir will tell you.
okay,
How
so,
it is.
so you do that,
While giving the block, no, block takes 10-15 minutes to act. How will you know while giving the block?
and also using nerve stimulation anyway.
Hello.
She is asking for blind.
Hello.
Yeah?
Hello.
Go on. Sir is also there.
One question is, if we are giving this paresthesia technique, then what is the stress where you see paresthesia?
Paresthesia technique.
Yeah.
Blind technique means.
I have not used much, so I can't comment.
Okay, sir.
We don't, yeah.
I don't
Okay, there's-
recommend also.
Yeah, yeah. I'll show them the,
Sir,
yeah, ठीक है, you. Okay, they want, the pinch is actually for, so you got the biceps, okay? So you ask them to actually pull you, okay, and then push you, okay, and then you pinch. Ask them to pinch their index finger. That is one pinch, and the second pinch is your little finger. Okay, do this. So these are two pinches.
This is not pinching like this.
Not that pinching. Yeah. Okay. This is what.
I thought it's pinching.
No,
like
this is pinch themselves. So you pinch.
Pinch
That
is
is
to make
their
a pinching movement.
and this pinch. Yeah.
Okay.
Okay. Yeah.
So this
basically,
was the opposition also. So
Opposition,
this was the unlearner.
yeah. Okay. So you're looking at biceps, looking at your triceps,
That is a
and
radial.
you're looking at radial and your median.
Median.
Ulnar, sorry, ulnar.
Pinch.
Okay. So push. So push, pull, pinch. Yeah.
Ha, please.
Dr. Sir, can you demonstrate that it is not needed technique for the demonstration?
Can you elaborate again? I can't listen. If somebody is. Speak louder.
Sir, can you demonstrate that you are using that technique cannula for catheter?
I cannot demonstrate in this patient. I have a video. That is. Chalo, the other patient is ready. They will show the landmarks. You can go on that patient.
Block the spine first.
Plexus block and
Okay. Done. And then at the highest point of our electrons.
Can you see the
That's the line
markings?
of tough ears. That is the when it bisect. That is the.
Okay, what that is, so you're going into soft tissue. You're doing that.
Between
Here-
L4 and L5.
Yeah, so what we're saying is, no, here you do is, you divide 1/3, 2/3, and you go on that. Okay, so basically what you're doing, this is your transverse process. Okay. If you're using this point, you're going to do soft tissue, you do not know where you're going to find it.
Shah and Dr.
Okay,
Shiv are
yeah.
doing the markings for this patient.
So can you describe the marking?
Yeah, okay. Can I have a mark? Yeah. So we,
This patient is having pain, so classic position cannot be given. But sir will tell you what he is doing.
can you hear me, Ethel?
Yes, sir.
Okay, so here what we need to actually mark the spine. So you actually feel each of the spinous process. You mark the spinous process.
Hello.
Yeah, hello?
Sir, mic adjust करना पड़ेगा.
मास्क दे दो, मास्क में लगा देंगे. Yeah.
You will use this. I will hold it for you.
Hello? Can you hear me now?
Yes, sir.
Okay. So the first line is you mark the spinous process. भाई मैंने क्या कहा है कि अपने उस पे keep it on silent please. It's very irritating.
We cannot hear you, sir.
मास्क लगा दिया ना सर.
हम
Can you adjust the mic?
एक मिनट. Hello, can you hear me now?
Yes, sir.
Okay. So first marking is you mark the spine. Okay, you have to mark each of the spine because in some patients they might have kyphoscoliosis, and you need to mark that. So that is the first line. The second line goes through your posterior leg spine. Okay, so you mark the posterior leg spine. Okay, and draw a line which is parallel to the first line. There are too many lines here, I think. Can we rub this out, please? Some spirit.
Can you adjust the camera?
Yeah.
Camera adjust.
Camera. Yeah.
Yes.
Yeah. Just there.
How is it better?
It's not rubbing out. Yeah. We've got too many. Yeah. Okay. Yeah. And can we have just a simple ballpoint pen?
Yeah.
Okay. Okay, so I'll do them again. So feeling for the spine. ये भी नहीं लिख रहा यार.
Spirit dry. Spirit dry.
Dry ghost की लुची ना.
ये dry है.
Dry good piece. Dry good piece.
I'm setting the marker then.
Yeah. Okay, that's fine. Can you see the marking? Hetal, can you see the markings?
Yeah. We can
Okay. So the spines are marked. Okay. This is the posterior leg spine, and this is a thin patient. It's nicely felt. So it's nicely felt here. So posterior leg spine. Okay. And draw the second line, which is parallel. So it need to be almost parallel to the first line. Then you go on the highest point Isle crest. This is diffuse line. And then you'll be going to do is divide into 1/3 and 2/3. So 1/3 up above and 2/3 below. And then we're going to go a centimeter or so below that. So we know that this is the interspace. Okay, so that is the transverse process. So idea is to hit the transverse process and walk off it like